We'll be moving on to our next session, which is telehealth, bridging the gap to access. Of course, telehealth has been in the news a lot this year with the national emergency, and our team is here to share some really good information with you to deal with all these changes that we've gone through. So, thank you for joining us for this presentation on telehealth. Today's presenters are Robin Kernel and Laura Wright, and they are both quality improvement advisors with the Kentucky Regional Extension Center. Robin has been a nurse for 25 years, with much of her career being in rural hospitals. Her nursing experience includes working at the bedside, covering the lifespan, but also nursing management and senior leadership. Her current focus with the Regional Extension Center is in telehealth, quality and value, and Medicaid promoting interoperability. Laura has been working in healthcare for over 20 years, and her experience includes decision support, EHR implementation and support, and revenue cycle management. Currently at the Regional Extension Center, she focuses on telehealth, quality and value, and the promoting interoperability programs for both eligible professionals and hospitals. We look forward to this presentation from Laura and Robin, and they have really focused on presenting this to help us both deal with the national emergency and beyond, and keeping patients safe and healthy. Please feel free to enter your questions in the chat or email them to us. And then if we have time, Robin and Laura will answer them at the end. Otherwise, we'll contact you directly after the event. Take it away, Robin.
Thank you, Catherine. We thank everybody for joining us today and sticking with us. We know it's been a long morning already. I'll let you go ahead and advance the slides. I think you can go past this one as well. Great, thank you. So here we have our objectives today. So we're going to take a look at telehealth through the lens of the pandemic that we're currently experiencing, and we're going to touch on how it impacts the quality payment program, what we expect after this public health emergency is over, and then, like Catherine mentioned, if we have time for some questions, we'll certainly take those at the end, or we'll reach out to you after today's presentations are over. So let's just get started with a brief overview of telehealth during our pandemic, and maybe just a little bit of the pre-pandemic. So with Medicare specifically, it was very specific on how Medicare applied services or payment for telehealth services. You were reimbursed specifically for primarily live video type services. There wasn't really an option for audio. They were specifically at an authorized distance site to a patient at a specific originating site. Patients could not be in their home, which has been something we have enjoyed during this public health emergency. They can do that now, right, for this term. Very specific practitioners were listed. And then probably one of the biggest hangups for most folks is that if patients seek services under federally qualified health centers or rural health clinics, those places where folks most commonly sought health care, those providers could not be a distant site, so they could not use those providers for their telehealth services. So those are some things that Medicare was very specific about. With the opening of these public health emergency waivers, we saw some very significant change. So we all know with Corona, which we all thought would be over much sooner than what it is, the declaration of the public health emergency, Medicare released these waivers that just blew the doors wide open for telehealth. And it afforded many options for Medicare beneficiaries. Several flexibilities become available. And of course, the biggest one was patients can access telehealth from home. The originating site is defined as wherever the patient's location. And Medicare had previously said that providing telehealth services to the patient's home was just not something they felt was feasible. And so now during this public health emergency, it does include homes or any other healthcare facility. Additionally, we can now use smartphones. And so this has really opened up the ability for patients to seek care and seek it in a safe way. And so now they can use options like FaceTime and Skype with these audio video capabilities now through what we call everyday platforms. Additionally, CMS added behavioral and patient education services, and then additional evaluation and management services to the list of services that were audio only. And we term it audio only because we know that not everybody has a smartphone with the video technology available to them. And so there are folks who still have landlines in their homes. I myself have one, but there are folks who don't have smartphones. And so this ability to check in with just a audio call actually gives a lot of folks some peace of mind. And those are reimbursable for this time being. Additionally, patients new to a provider can participate in a telehealth visit. Previously, outside of the public health emergency, you had to have an established relationship before you could provide a telehealth services, and this has been temporarily released during this emergency. The next waiver that's happened is cost sharing. So there's no penalty now for limiting or eliminating deductibles, copays, or co-insurances associated with telehealth visits. So that's made this, again, more accessible for patients. And then finally, all providers are eligible to use telehealth. On our previous slide, we had a distinct list of providers who had who were only able to provide the services, and with this waiver, it's been opened up to all providers. So regardless of the service you need, that's been made available to you. So this came about mainly because there were folks who really needed therapy services at the start of this pandemic, and they, maybe had total hips and total knees and various other things that were requiring physical therapy and occupational therapy, and that's just something you can't just stop. So they petitioned for a waiver, and they were granted that. And so now those can be provided through telehealth as well. And then some even were able to get that back in service in person in addition. So the next slide, we'll talk about the state legislation. And so Kentucky Medicaid has been a lot more flexible than Medicare has when it comes to telehealth services. There's even pre-pandemic, the rules were a lot less when it comes to the type of services that could be provided and payment parity and things as such. So there wasn't as much for them to release when it came to waivers. So that's been fortunate for our Medicaid recipients. One of the biggest things that's happened in the last couple of years is payment parity, which means it's a law now that regardless of your payer source, the services that you provide, if they can be provided via telehealth, but also provided in person, the payment for that service has to be the same. You can't reduce it just for being a telehealth service. And I've mentioned they were less restrictive. So there weren't limits on what types of services could be provided via telehealth. If you can provide it, in person, and you can safely provide it via telehealth, you could provide that for Medicaid beneficiaries. More recently, the state telehealth program is undergoing a revamp, and we've provided the new website here for you, and it's been ongoing and even throughout this pandemic, and so we'll see more to come from this, but essentially they're trying to make the telehealth more accessible for their Medicaid beneficiaries. They want folks to be able to utilize this service regardless of their location in the state. They want to make it easier for providers to be credentialed, patients to have access to specialty outside the state, whatever. It's a very lengthy process, and we're fortunate, those of us with the REC have been able to be part of this team at the state level to help promote this and then also be a part of the education and the rollout. So more to come with that as we see this program develop across the state. So one of the things that we've saw from the beginning of this pandemic, and these numbers here that's on the slide are a little older, but it was an unprecedented adoption of telehealth visits. We knew that we had patients who still needed to be seen. They still needed to have well visits. You have folks who are healthy that didn't want to be visiting their provider in the clinic. The providers didn't want their healthy patients being exposed to patients who were sick, and there was just so much going on at the beginning that once these waivers were rolled out, people really took advantage of this option. So we saw from just pre-COVID levels, 175 time increase in the number of those visits provided. Blue Cross shared that they saw a 3,500% increase in claims just in February and March, and then Medicare as well. And then more recently from CMS Administrator Seema Verma, traditional Medicare has seen the number of remote visits increase from 12,000 per week to just over 1 million per week. And that's through this last month of reporting. And then we here at UK have saw a significant amount of telehealth visits, and it continues to be ongoing as well. When we talk about provider and patient satisfaction, at first folks were a little afraid of it. It's technology. We weren't sure what kind of connection we'd have with our patient. We weren't sure what kind of connection we'd have from our provider. Are they going to look at me? Are they going to look at the screen? Are they going to look at the computer? What are we going to see? And so some surveys were done and early on just to see how perceptions were, and it found that patients really approved of the quality of the telehealth interactions, and they were reporting it with a high satisfaction. And many folks are really positive about that quality of their interactions and that they were able to maybe have a little more one-on-one time with their provider. There weren't the distractions that maybe they would have in the clinic. There wasn't that option to just knock on the door if somebody in the clinic needed the provider. They couldn't be interrupted as well because they weren't necessarily seeing patients within the clinic. The provider themselves may be at home seeing their patients through audio or video technology. And then providers themselves warmed up to this option. They found that it was they viewed it more favorably before COVID, and they were more comfortable using the technology. And then more recently, even there's a COVID-19 healthcare coalition that's been established to actually evaluate how providers have felt about this program and using telehealth over the last 8 months. And more than 80% of the responders to this coalition survey report that telehealth improved the timeliness of care for patients. And then 75% of those that replied felt like they were still able to provide quality of care. And some even said that they felt like their patient's health had improved because of the use of telehealth. So moving along to the impact on the quality payment program, I know Kelly and Jessica talked to you all this morning about this. We want to talk just specifically about how telehealth may impact your documentation and how the improvement work may impact your quality measures. So we'll start just with a few quality measures. So there are 42 telehealth eligible ECQMs for the 2020 program year. It's important that you review your specification sheets to determine if the telehealth visits are included. And so you can pull those down from the website that we have listed here on the screen for you. You can look within that specification sheet for your quality measures in which you chose to report, just to be sure that you're including all of the applicable codes. Just because you've elected to see a patient through telehealth does not exclude the patient from your population. So keep that in mind. They are still falling into your initial population if you're providing an E&M service that qualifies for that quality measure. Originally, there were 4 measures that were very commonly reported that were being excluded. Unfortunately, those have been altered. And so 2 of them are now included. One of those being influenza vaccination and the second one being tobacco use and screening. Originally, these 2 were being excluded, and fortunately, CMS recognized that these were actually patient-reported quality measures and that these could be documented against and count underneath the CQM documentation for your providers. The other two that are very commonly reported that are still not approved for a telehealth documentation are the BMI screening and follow-up and screening for high blood pressure and follow-up. And the reason for those two simply are that they require a documentation of a clinical parameter. So of course you have to weigh the patient for BMI, and then you have to take a blood pressure. Now with remote monitoring becoming more popular, those may change in the future, but we haven't seen that yet. So unfortunately, BMI screening and follow-up is not a telehealth measure, and neither is screening for blood pressure and follow-up. So we encourage you that you take your measures that you're reviewing and that you review those spec sheets just to make sure that you're not missing any documentation. And then as a reminder that if you're providing that service via telehealth, those patients are pulling into your population. So don't forget that. All right, our next slide is about improvement activities. So there are 4 improvement activities that can be centered around telehealth services. The first one we have listed, there's chronic care and preventive care management for impaneled patients. And at first glance, you wonder how that actually applies. But since some of you are completing your annual wellness visits with your Medicare beneficiaries, that does fall under the chronic care and preventive care management improvement activity. So those folks can be incorporated under your improvement activity, since the annual wellness visit can be provided via telehealth with audio or audio only or audio and video technology. And then as well, some folks can self-report their vital signs for this improvement activity. It doesn't count for the quality measures I mentioned, but it will count towards this improvement activity. And then of course, the second one listed there is the use of telehealth services that expand practice access. That's a pretty straightforward one. And then additionally, real-time access to your electronic health record after hours or extended hours. And then the newest one that's been added is participation in the COVID-19 clinical trials. So if you elect to choose one of these improvement activities, of course it is later in the year, it's December, but it's important that you go back and you review the measure validation forms so that you are maintaining the correct documentation in case of an audit. If you go back to the quality payment website and pull up the improvement activities, it'll give you a direction on how to reach that validation criteria, and you can see what the necessary documentation is to maintain to prove that you are keeping the correct information. All right. So now I'm going to pass the remainder of the presentation over to my colleague, Laura Wright.
All right, thanks so much, Robin. Lots of great information there. So I get to talk a little bit about telehealth after the pandemic. And I know we are all tired of hearing about the pandemic, COVID-19, coronavirus, whatever you want to call it. Healthcare workers are tired, parents are tired, our teachers are tired. I mean, just everybody is tired, and we're all looking for the future of when this public health emergency period is going to be allowed to expire. And we don't really know exactly when that is just yet. We do know that it was extended until January 20th of 2021. Whether it will be extended again at that point, I guess we'll just have to wait and see. So we wanted to discuss a few considerations that you should make if you want to continue offering telehealth services to your patients after the pandemic, or maybe you haven't really started offering telehealth yet, you've been considering it, but you haven't started. There are probably some helpful tips in here for you as well. So again, once the public health emergency is over, we don't know exactly what aspects of those waivers that Robin discussed earlier could stick, or which will go away and revert back to the pre-COVID restrictions. However, when it comes to those looser HIPAA requirements around software platforms, most would agree that this is one area that will not and should not remain as flexible, because obviously patient privacy and security is of the utmost importance. So we recommend that if you jumped into telehealth quickly and started using those apps such as FaceTime or Skype, like Robin mentioned, are available under the waivers currently, then we recommend that you should upgrade to a more HIPAA compliant platform for patient privacy and security. And you probably want to go ahead and start thinking about that now before CMS does put some sort of deadline on this. Again, we know the PHE should, right now, is going to expire January 20th. And again, that could be extended. But you don't want to get to that deadline and then have to just maybe stop immediately offering telehealth to your patients. Now, we had a couple of clients that decided to take a little bit slower approach when they implemented telehealth. They did their due diligence and they selected a platform that would give them that security they would need so that they could sustain their program even after these flexibilities go away. So again, if you're just starting a program yourself, that's probably the best approach for you at this point as well. You'll also want to consider the broadband availability and access to technology of everyone involved. So not just you and your practices or hospitals, but also your patients. Unfortunately, we've heard a lot about patients not having access to either the technology to support a video visit or them also maybe not having good enough internet at home to support telehealth visits. And in fact, we've actually heard of patients having to drive all the way to their clinic and sit in the parking lot so that they can pick up the Wi-Fi necessary to participate in their telehealth visit. And maybe that was a good option to get that patient to be seen immediately. But when you think about the long term, this really isn't a good model for sustainability and not something that you would want to keep having your patients do. Now let's think about staffing. So we know a lot of your staffing models have looked quite a bit different during this time. They probably looked different in the spring when COVID first hit, and then maybe they regulated a little bit over the summer, and now maybe you're having to make adjustments all over again. So when you look at sustaining your telehealth program in the future, is your staffing model working? Do you have the appropriate staff to continue offering telehealth services once everything normalizes? And then on the other side of things, when you're considering implementing a telehealth program, there are several considerations to make around your staff, such as their level of comfort and skill in using the equipment and conducting visits virtually, their current workflows that you have in place already, and the staff's current capacity. And then finally, scheduling. So early on, you may have wanted or simply needed to intersperse telehealth visits throughout the day just to be able to get patients in and get them seen. However, when you're looking at the future of your telehealth program in the long run, that's not necessarily efficient because when you're doing that, you're utilizing all of your office resources such as your building, your utilities, and your staff. So when you scale, the better strategy could be to bundle your telehealth appointments. That way, your provider could potentially be at home seeing patients where their overhead is going to be much less, or maybe they're seeing patients at the end of the day when some of your support staff has gone home and you're not utilizing your entire building. And really the reason I'm mentioning this and the thoughts about the overhead is because we may get to a point where telehealth is not necessarily reimbursed at the same rate. So right now we do have that payment parity in place where you are getting reimbursed for these telehealth visits at the same rate as you would for an in-person visit. That's another area that we don't really know what the future is going to look like. We don't imagine that everything is going to be one-for-one in the future of telehealth, really because your work is any less with these patients. But when CMS and the payers are looking at your reimbursement for telehealth services, they know that theoretically your practice expenses should be a little bit less, and that will factor into that reimbursement. And so telehealth may only be viable to you if you can reduce some of those overhead expenses related to your telehealth visits. Now let's talk about some legislation that's been introduced around telehealth as we're looking to the future. So CMS, as we mentioned earlier, CMS just released that final rule related to the quality payment program where they did address telehealth somewhat, although for me, I know it was a bit disappointing that we didn't see more sweeping changes. Again, as Robin mentioned earlier, CMS does not allow patients to be seen from home in this, aside from, the waivers that are currently in place. I know that's one area that we would love to see changed, and that really wasn't addressed in this final rule, except to confirm that the patient's home can be used in the treatment of substance use disorders and co-occurring mental health disorders, as that was established in the Support for Patients and Communities Act previously. Now, CMS is adding 9 new HCPCS codes to the list of Medicare telehealth services, And they also updated a few guidelines around remote physiologic monitoring and established that the temporary codes that were allowed to be used during this public health emergency will remain active through the end of the calendar year in which the PHE expires. So basically, CMS recognizes that once that PHE expires, if you're using some of these codes that are being temporarily allowed as telehealth services, you might not be able to simply stop using them as soon as that PHE expires. So CMS is going to allow you a little bit of wiggle room to continue using those for a while. Now, recently, the Home Health Agency's final rule was also released, where CMS recognized that there are ways technology can help improve patient care and outcomes. And so they finalized amendments made during the PHE. This will allow the use of telecommunication technologies for patient care as long as it is included in the plan of care, and it may not be substituted for in-person home visits. And then it also expands the definition of telecommunications technology and remote patient monitoring. So it is good news in the home health agency world that we did see CMS recognizing some of that technology and making some improvements on that side. And then even though we didn't see a lot of sweeping changes in the physician fee schedule final rule, there is a little bit of hope in the future. So there are a couple of acts that are currently at the legislative level that are addressing making changes to the way telehealth can be offered. So those acts are the Protecting Access to Post-COVID-19 Telehealth Act, and it was introduced in July of this year. And then we have the Advancing Telehealth Beyond COVID-19 Act of 2020, and it was introduced the month prior in June. Now, both of these call for permanent expansion of telehealth services, including lifting some of the restrictions around patient location for Medicare beneficiaries. And then also they talk about lifting some of the restrictions that federally qualified health centers and rural health clinics currently have in place. And then finally, there are some OIG assessments that are ongoing where CMS is exploring whether the flexibilities afforded during this public health emergency should be extended. Now that, again, those assessments are ongoing. They're looking at a couple of different ways, and those were announced in May of this year, and they are expecting to issue a report around that sometime in fiscal year 2021. And then finally, this past summer, a task force on telehealth policy was actually formed in order to formalize recommendations for remote healthcare delivery nationwide. They met over a series of a few weeks and discussed a lot of issues around telehealth. They discussed the current waivers that are in place and whether some of those should be extended beyond the public health emergency. It was a very large group, and it had participation from health plans, providers, consumer advocates, and health quality experts. So there were a lot of different areas weighing in on this. They released their final report in September, and just wanted to highlight a few of the things that they talked about in their final report. So first, they agreed that telehealth is a natural evolution, and it really is the future of healthcare, and so it should be recognized as such. They also recognized that telehealth replaced a lot of in-person care without actually increasing costs during the pandemic. And in fact, it also helped relieve travel burdens, risks, care delays. It helped improve behavioral care access and also helped to reduce missed appointments, as well as helping to reduce costly transfers to hospitals and EDs and hospital readmissions. Now, they did recommend that the HIPAA enforcement should resume after the public health emergency ends. And again, I don't think any of us are too surprised to see that recommendation. And then finally, they feel that value-based arrangements should enhance the ability of patients, payers, and providers to leverage telehealth's potential. So essentially, they should really recognize telehealth and make it a little bit easier for providers to use telehealth in caring for their patients. And then also, they did recommend that a few of the waivers that were in place during this public health emergency should be extended beyond the public health emergency. And those include lifting some of those geographic restrictions on the originating sites, expanding those clinician types. As Robin mentioned earlier, pre-COVID, providers are really restricted on what clinician types can provide telehealth in Medicare's eyes. And so they do recommend expanding those clinician types. They also recommended removing that established patient requirement. So again, as Robin mentioned earlier, pre-COVID, providers did have to have an established relationship with the patient and could not see new patients via telehealth. So they do recommend, this task force recommends removing that requirement. And then they also recommended lifting restrictions across state lines. Now, I don't believe we're going to have a lot of time for questions, if any. So I want to remind you, just put them in the chat and we will get those questions and we will reach out to you individually. And then finally, just wanted to remind you that whether you have already implemented telehealth or just starting to think about it, we can help by either assisting you with optimization of your program by looking ahead and ensuring it's sustainable, to providing implementation support and resources. So we're always happy and willing to help. And I think everyone has shared our contact information, so I think you're good there.
Thank you so much, Laura and Robin, for sharing about telehealth, which is on everyone's minds right now. And as Laura said, you can either put your questions in the chat or email us or call us. We're available and we'll forward the questions to our team to answer directly.